Sir, we'll wait for 2 more minutes and then we'll start the class, sir.
Yeah, okay. Done.
Class kuda chinnadalandi sir, 25-30 slides ante.
25 slides. The same sheet is important.
Okay.
Omkar.
Sir, good morning, sir.
ఒక్క స్లైడ్ మీద 1 hour కూడా మాట్లాడొచ్చు నీళ్ళంటాడు.
అయ్యో సార్, ఏ సార్ ఈ క్లాస్ కి మీ గురించి కూడా కొంచెం ఉంటుంది సార్, కొంచెం చెప్పాల్సింది.
Good morning, sir. Good morning, Omkar, sir.
గుడ్ మార్నింగ్. ఏదైనా తప్పులు చేసి చెప్పు ఓంకార్, నా గురించి చెప్పేటప్పుడు అందరి ముందు చెప్పు.
లేదు సార్, ఈ టాపిక్ చూసినప్పుడు అంటే ఇందులో స్లైడ్లో నేను పెట్టలేదు, కానీ ఒక పాయింట్ మీరు నాకు చెప్పింది చెప్తానన్నమాట. ఇంట్రడక్షన్ అని చెప్తానులేండి సార్, మంచిగా చెప్తాను సార్, కంగారు పడకండి.
ఇట్స్ ఓకే, ఈవెన్ నెగిటివ్ చెప్పినా తప్పలేదు, ఉపయోగపడేది అందరికి.
అందరికి నాకైతే బాగా ఉపయోగపడింది సార్. సో నాకు తెలిసి అందరికీ ఉపయోగపడుతుందని అనుకుంటున్నాను నేను. Sir, we'll start, sir.
Start చేయండి.
Okay. Good morning, all. Today I'm going to talk about advanced airway assessment techniques. So first thing, whenever a patient comes to us for pre-anesthetic checkup or in an emergency, when we go to ER and check the patient, we mostly look into our what you call our department side, like difficult cannulation, difficult intubation, everything. How can we hold the mask? What sort of anesthesia are we going to plan? So in most of the cases, we assess airway basing on our age-old techniques, but in some cases we face some significant challenges. So this class is about that little percent of cases where we are facing difficulty to hold the mask or to intubate. Even though our prior assessment was good and we felt it can be done, but under anesthesia in operation theater, we are encountering some sort of difficulty. So I'm going to talk about the reasons why this, why our predictions are going wrong and what can be done. So when it comes to talking about difficult intubation, so one of our senior consultants around 4 years back, he told me there are two types of difficult intubations, which are difficult by anatomical or else any other pathological issues. They are difficult, and the second group is they are made difficult by improper positioning, by not having adequate mouth extension, not positioning well. So made difficult, call for help will always help you, because senior consultant will come and he will correct your mistakes. But which are difficulty, which are pathologically they are having some issue, so this class is going to help us in what you call assessing this kind of patients who are seriously having some pathological issue but clinically not having any complaints. So our traditional assessment methods which we do bedside are lacking some sort of sensitivity to predict the exact difficulty of mask ventilation, laryngoscopy, and tracheal intubation. So their predictive value is, frankly speaking, bit poor when it comes to these conditions. So what sort of patients am I talking about? So mainly this group includes our assessment will be mostly what you call wrong in head and neck cancer patients, especially pathology of tongue, epiglottis, larynx, glottic openings. So these sort of patients, where we regularly ask them to open their mouth, see tongue, mouth opening, teeth, and all, and we come out, and we finally come to a conclusion that this can be done so and so. But these sort of conditions where pathology is in the base of tongue or else epiglottis, we miss them. Yeah, I agree. We may, what some of you may say that Karman-Slahan grading is also there, but regularly we don't do that. And next thing is we do some investigations like X-ray, lateral view, neck, CT, MRI, and these all give us a static snapshot of airway, what you call anatomy, not the dynamic way. What I mean by saying static and dynamic, when you come to CT, say CT chest or neck, where while the CT scan is going on, patient is asked to take deep breath and hold the breath. But when we deal with the case, we need to know about what is happening once we induce. Because when patient is awake, he is having a tendency to maintain his airway. But once induction dose is given, everything will be, what you call, reflexes will be collapsed, and there will be desaturation. So this desaturation, which happens, varies to patient based on the underlying pathology. Pathology at the vocal cord, they desaturate very what you call fast. So these things, we need some advanced techniques to assess situations like this. The fourth national audit project of Royal College of Anesthesists and Difficult Airway Society observed airway management of patients with head and neck cancer was considered poor in nearly 30% of these cases. So this 30% included some cases where they were not having any clinical complaints. So what you call induction doses were given, and later on they landed into some sort of complication. Okay, and in selected high-risk patients, advanced airway assessment techniques such as nasal endoscopy, visual endoscopy, and ultrasound is being introduced. When I say selected high-risk group, these are most commonly head and neck cancer patients, post-surgery patients, and patients who are having some syndrome like Piri Robinson syndromes. So these are all these patients come into high-risk group. So coming to nasal endoscopy, most commonly we know that these things are done by ENT people, not by us. So these things are also needed if we need to assess our airway. So nasal endoscopy most commonly for MLS surgeries, what you call ENT doc get do that, what you call flexible nasal endoscopy in their OPs only, and see that vocal cord and all. They tell us about the tumor is here and there, and there is vocal cord movement. So this part helps us in assessing our plan of anesthesia, how difficult it is to do the thing. When in flexible endoscopy only, if the visualization of cords were difficult, I think that is a point where we need to be extra cautious, and we need advanced techniques to deal with the patient. So why do we need endoscopy? We need this to just increase the patient's safety. So flexible and nasal endoscopy involves to visualize the nasal passages, pharynx and larynx, and what you call any pathology at retinoid or base of the tongue or anything. So these things can be visualized, and even their location, with the point of location of the tumor, we can assess. Okay, this is located here. If I'm giving any anesthesia induction dose, this may easily obstruct the airway. So this is the point where I am supposed to concentrate. So it helps in formulating a safe airway management plan. The preoperative endoscopic airway examination, which is called PEAE, which is also commonly called as nasal endoscopy or NAS endoscopy, is the only technique that assesses the upper airway in its entire under dynamic conditions prior to induction of anesthesia, and is recommended for routine use by NAP for even for high acuity cases. So let's look into a case scenario. In this case, nasal endoscopy was done. So a 78-year-old woman with recurrent T2N2 squamous cell carcinoma of right neck, status post modified radical neck dissection, presented on the day of surgery for elective direct laryngoscopy and biopsy of 3.5 centimeter supraglottic lesion originating from right piriform sinus. So actually, these exact specifications and all, she underwent imaging and also endoscopy was done. To make our understanding easy, I mentioned everything here. The mass involved the base of epiglottis, right area epiglottic fold, and was impinging onto and displacing the area. The patient lacked symptoms of upper airway obstruction such as hoarseness, voice, stridor, nocturnal air hunger. The patient past medical history was otherwise unremarkable apart from this CA treatment. She was physically active, presented with stable vitals and body mass index of 28.5 kg per meter. The laboratory results were absolutely normal. The external airway examination revealed adequate mouth opening and Malampati class 4 airway, what you call scarred neck with full range of motion, normal thyromental distance, normal mandibular protrusion, and submandibular compliance, and normal identifiable cricothyroid membrane. So with this picture also, even so, the picture they have mentioned class 4 MP, but looking at the picture, I think it's around 3. But other scenarios, other complaints like any air hunger, difficulty in breathing, mouth opening, nothing is present in this patient. So most of the time, we may plan our regular routine, what you call techniques for intubation of this patient. So significant concerns were raised about the success of post-intubation mask ventilation and laryngoscopy. The size and location of the tumor and the presence of at least two predictors of difficult video laryngoscopy, a neck scar, otolaryngoscopic surgery, and with all these things, what you call scopy was problematic, and direct laryngoscopy was considered not feasible. The PEI revealed a large subglottic right piriform sinus mass extending into valvula and significantly displacing the epiglottis and laryngeal inlet. So neither a ball valve phenomenon or glottic obstruction was present, and there was no associated preglottic edema or vocal cord pathology. So this was the view in what you call endoscopic airway examination. You can see there is opening, this vocal cord opening, and just beside towards your left there is a big mass. So even though this mass is present, the airway is not completely getting obstructed. So the patient was comfortably doing her work and able to take breaths, and she was not having much of difficulty. But this mass, if it grows in future, she may land up in some sort of problem. Okay. So this demonstrated the submucosal subglottic lesion extending into valvula and producing a fixed displaced upper airway narrowing, but without any clinical complaints. So the presented case demonstrates the successful management of an anticipated difficult airway aided by PAE in the setting of patient airway obstruction and largely unremarkable external airway examination. So in our endoscopic examination, it was helpful to know that there is some sort of an anatomy in the airway, especially the dynamic what we call condition of the patient was exactly assessed. Why is this required? So this is mainly required to decide, should I try any intubation technique under sedation or in awake condition. So this patient was having some sort of what we call pathology, but clinical symptoms were less. But the pathology was lying just beside the vocal cords. Okay, so their further plan was decided basing on PAE. The PEI findings proved essential for deciding on awake versus sleep approach to the traditional intubation and for devising safe ventilation and intubation strategies after induction of general anesthesia. So the nature of supraglottic obstruction and a pathological process involved created a fixed upper airway narrowing without associated valvular phenomenon or abnormal airway dynamics. These findings were reserved for successful mask ventilation. So the next part of this case was uh, they did not induce or sedate the patient. They used all regional techniques like blocking what you call airway. They gave airway block and then further proceed for intubation, and successfully they have done the intubation. And even for these intubation techniques also they used ultrasound and all. The PA is the only technique that allows the anesthesiologist to visualize the degree of obstruction and tumor mobility directly. It is effective, fast, and well tolerated a point of care tool, and is considered a minimum required level of investigation to guide us. Though this statement's bit of controversial, I don't think all patients will be cooperative and comfortable in getting endoscopy done. So how do we do it? The PAE is performed with patient awake using flexible endoscopy, a decongestant, a minimal amount of topical anesthesia, 2 to 3 ml of 2% or 4% lignocaine, and it can be done in minutes. So even in urgent situation, PAE may help with anticipation planning for a difficult airway. Urgent situations like any what you call nasal bleed or else facial-maxillary trauma, in these conditions it may help us. Next is virtual endoscopy. So this is something new for us, because most of the time this virtual endoscopy is all mostly done by radiologists only. So for many years, radiologists have been using multi-dimensional image navigation and display software to create a virtual endoscopic image of tracheobronchial trees. So this next statement is what you call, frankly, it, uh, what you call, completely it goes to radiologist only. We only just see an image and we plan. But from now, because of this advanced techniques, they are discussing with radiologists, getting a 3D image done and understand how the airway is and what are the difficulties which we are going to face. So these have been used to aid in pathological diagnosis and CT guided biopsies. Having been introduced to this existing free technology, we wanted to establish whether we could help us as airway anesthesiologist. The 3D endoscopy software function was utilized to construct a 3D film, 3D flight path by advancing and rotating a virtual camera to stimulate endoscopic view. So that's what I said. Using all these images, they create a 3D image which helps us to understand the airway. The virtual endoscopy potentially bridges the gap in airway assessment by providing a non-invasive, anatomically accurate representation of the patient's whole airway for naso or oropharynx to the carina in a format familiar to all anesthetists. So, what is how means what is happening? How are they creating all these things? So they use some software. So this next statement is like Greek and Latin to us. But to understand what are the limitations of this technique, we need to know about this. The patient's pre-existing diagnostic CT images can be reconstructed into a 3D fly-through video of endoscopic anatomy using the Osiris View software. This can contribute to planning airway management strategies well in advance of any direct patient intervention and therefore risk of harm. So, what are the limitations of doing virtual endoscopy? The quality of fly through videos are dependent on the quality of the uploaded PICOM data files. So it is sort of files where every image is taken into, and we can improvise the image, and high quality image is saved in these files. Using these files only, the reconstruction of airway will be done. So small lesions may not be reconstructed, natural color will not be there, and excessive smoothing of the airway may occur, and it is static and not dynamic examination technique. As I already told, images, they take the picture of static condition of the patient, and we do everything basing on that static view of the airway only, not the dynamic view. So again, we have a problem with this, that we cannot take an exact decision that can I try intubation after giving any what you call induction dose or not. This point we will this decision we cannot take basing on this visual endoscopy. So which will we can assist in making a more accurate airway assessment, formulate a more cautious airway plan, and provide a virtual run-through video of best path for the fiber scope, what you call fibroscopy, potentially further reducing the failure rate of this technique. We has the potential to reduce the number of airway complications in patients with head and neck pathology. Although further studies will be required to demonstrate this. So why further studies? After taking all these images, we again they do what you call nasal endoscopy also, because as I said, minimal small what you call tumors, they will be missed in this imaging techniques. And by doing endoscopy, they will find out any excess what you call tumor is present, are we missing anything. By combining visual endoscopy and nasal endoscopy, finally they proceed to further plan of anesthesia. And the third thing is ultrasound, which is available for us in day-to-day life. Ultrasound is also being widely used nowadays for assessing airway, and also to see is the intubation done in esophagus or else lung. The point of care ultrasound focus can be used at various stages of airway management, from airway assessment to confirming the position of the tracheal tube and readiness for extubation. An ultrasound machine with both high frequency, linear, and curved probe are sufficient to scan the majority of the airway structures. So ultrasound can be used for what all purposes? First thing, preoperative airway assessment, tracheal tube size, prediction of pediatric ETT and double lumen tube size, vocal cord assessment, assessment of tracheal intubation, cricothyroid membrane, tracheostomy procedures, post-extubation stridor. So these 7 points where ultrasound is being introduced, they help us a lot. So preoperative airway assessment, coming to tongue size. Tongue thickness may affect the ease of direct laryngoscopy and intubation, and it can be measured using a curvilinear ultrasound probe in the submental and median sagittal plane. A tongue thickness of greater than 6.5 centimeters and a tongue thickness to thyromental distance ratio of greater than 0.87 have been shown to be independent predictors of difficult tracheal intubation. So actually, position of probe and all for this tongue size examination, I did not get any pictures, so I just mentioned it. So what you call in submental area visualization, we have to see for the tongue and calculate the thickness and thyromental distance regularly. How in our what you call regular bedside assessment, how we measure thyromental distance, we will measure the distance and take a ratio of both of these. If it is more than 0.87, then we can assume that it's going to be difficult for intubation and for tracheal intubation. Fasting status focus is rapid and non-invasive technique, and it is useful to estimate volume of gastric fluid in adults and pediatrics. The prediction of difficult laryngoscope in obese patients. So the pretracheal soft tissue at the level of vocal cords is a good predictor of difficult laryngoscope in obese patients. Though clinically also we can assess this. with ultrasound we can do it in a better way. And how to measure pretracheal soft tissue? So the distance from the skin to the anterior aspect of trachea is measured at three levels, like at vocal cord, thyroid isthmus, and suprasternal notch. So at these three differences, the measurements are taken. The amount of soft tissue at each level can be calculated by averaging the amount of soft tissue in millimeters obtained in central axis of the neck and 15 mm to the left and right. So what they do is they take the probe, they measure the distance from the skin to the anterior aspect of trachea in midline at the level of vocal cord, thyroid isthmus, and suprasternal notch, towards right, towards left, and they take an average of everything. So when they finally sum up these things, a patient who had more pretracheal soft tissue, that is 28 mm, and a greater neck circumference, 50 centimeter, at the level of vocal cord, are having a chances of encountering difficult laryngoscopy. Okay. So tracheal tube size. So ideally, how we decide tracheal tube are age-old formulas, age by 3 plus 3.5 and age by 4 plus 4.5. And coming to ultrasound, point of care ultrasound helps us in assessing the tube size also. Um, a reliable tool for assessing the narrowest diameter of the cricoid lumen, this transverse diameter. In pediatric patients, subglottic upper airway diameter measured by ultrasound is a good predictor of correct cuffed and uncuffed ET tubes. So what they do is they measure the point of they measure the diameter of the opening by using ultrasound, and with that diameter they compare the diameter of the ET tube which they are going to use. Okay, by comparing these two we can assess which tube can be comfortably introduced. Normally in pediatric age groups we go for snugly fitting. We estimate according to our formula or by looking at the baby, because at the same age children's growth might be different. So by using ultrasound before going to induction only, we can decide what is the tube which we are going to use, and after further proceed for intubation. So this can be performed in children to estimate the tracheal tube size required, or in adults to demonstrate any degree of tracheal deviation and stenosis. And one more important point, especially dealing with pediatric patients, is subglottic narrowing. Many times when we intubate, we can encounter conditions where after our ET tube passes the vocal cord, there will be obstruction. There will be the tube will not be passing easily. There will be some obstruction. That is because of subglottic narrowing, which is most commonly seen in pediatric age group. That condition we can assess by using ultrasound, and we can decide about the exact ET tube which we can use. How to do it? So I don't I think images are bit clear, so I will try to explain how to do. To measure the width and location of underlying trachea, take a linear probe in transverse mid-tracheal position. See, look into the picture A, the first picture where the transverse, the probe is kept transversely on the cricoid ring, where you can see the cricoid ring, that is C, and trachea. And in image B, this transversely kept probe is now rotated, and it is kept in sagittal plane, and now we can see what you call uh, in sagittal plane. The first thing TC, that is we can see thyroid cartilage, and that white line in picture B, when you come down, that is cricothyroid membrane. Further down we can see cricoid ring. coming to play picture C, that is right sagittal view. In right sagittal view, we can see cricoid ring C, that is cricoid ring. After that, trachea, and following that, tracheal rings. These tracheal rings, we can see them as what you call small uh, uh, small chain with rings. That is tracheal ring 1, tracheal ring 2, mentioned as TR. Next, vocal cord assessment. So this is another technique where we use linear probe transversely. We directly place on what do you call our just above the Adam's apple. The vocal cord and adjacent structures can be visualized with the linear probe placed transversely at the thyroid window. This technique has been used in the preoperative assessment of vocal cord movement in patients undergoing thyroidectomy. The allows the assessment of superior and right recurrent laryngeal nerve function after thyroid surgeries. So, see the picture. It shows anterior commissure top up, which is mentioned as AC, followed by vocal cords VC. Coming more laterally, it is arytenoids which are present. So movement of these things, by how do they do that? They put the probe, and once the visualize is done, they will deflate the cuff. Once the cuff is deflated, and they will also see that patient is in lighter planes. So once patient starts bucking, they will observe the movement of the vocal cords. Both the vocal cords, are they moving or not? Once they are confirmed that movement is good, again what you call they will plan for extubation. After again inflating the air with minimal air will be given. In some conditions, what they do is, once surgery is done, to get a better view of airway, because our cuff, we inflate air, it is also having air, and in vocal cord both the view will be black, we cannot differentiate. So what they do is, initially they remove the air, they see for movement. Once they are confirmed, they take some saline, and they inflate the saline in the cuff, so that they can easily differentiate between air and saline in ultrasound. So this is something, this is called 3D probe. For better view, what they do is, because these are all very superficial and just below the skin, for better visualization and differentiation, they take one air bag and put the 3D probe on that, on the neck, and try to visualize the vocal cords. So assessment of tracheal intubation. So our age-old technique, after intubation, we check for bilateral air entries and all. And in ultrasound, what they do, we'll see. Confirmation of tracheal tube placement with the waveform capnogram is the gold standard method. Focus can be used for identifying esophageal intubation before attempting ventilation. Ultrasound imaging can visualize the motion of diaphragm and pleura, indicating lung expansion, and indirect but dynamic anatomic evidence of correct physiological function of ET in paralyzed or apneic patients. So by after intubation, we connect the tube, we connect a back to it, and do gentle ventilation. We don't give full of tidal volumes, because with ultrasound, even the minimal chest movements we can uh, see in the image. We can see with the probe. So if we are in esophagus, or if we are in lung, we can easily differentiate. So how do we do it? If ET tube is inside the trachea, if ET tube is inside the esophagus. So bilateral equal motion of the diaphragm towards the abdomen can be seen by ultrasound. Further, with intercostal ultrasonographic view at the lung chest wall interface, to and fro movement of pleura synchronized with ventilation, lung sliding sign can be visualized. Esophageal intubation, ultrasound shows an immobile or paradoxical state of diaphragm. Ventilation through esophageal position ET tube can also result in paradoxical motion of diaphragm, in which diaphragm moves towards the chest due to increased intra-abdominal pressure as a result of distress of stomach caused by positive pressure ventilation. So this is very important because movement of diaphragm, if the tube is in lungs, it will be towards what you call downward movement of the diaphragm will be there, and if it is in the abdomen, with our ventilation the diaphragm will be pushed up. Endobronchial intubation. So, and the differentiation between tracheal and esophageal intubation is will be difficult if the patient is having some sort of lung pathology, where we cannot understand the what you call, if patient say some ARDS patient where air entry will be hampered to some parts, and and it is a difficult intubation, and patient goes down on saturation even with oxygenating. So previously what they used to do is intubate, take two tubes, put one tube in esophagus and other tube in lung, and check for what you call better lungs auscultatory sounds by ventilating on both the sides. To avoid all these things, ultrasounds will be very helpful. So endobronchial intubation. So what happens? Same. We can see lung sliding sign in ventilated lung, and in non-ventilated lung, absent or restricted movement of the diaphragm, and absence of lung sliding sign. Then cuff inflation with saline instead of air to detect position of ET tube in case of an already tracheal intubated patient has been described. This was mainly to get a better view. Ultrasound of pediatric airway can be easily used to assess correct tracheal position and to detect esophageal intubation. So there are some criteria which has to be followed. And first thing is identification of trachea and tracheal rings, and visualization of the vocal cords, widening of glottis as the tracheal tube passes through, tracheal tube position above carina, and demonstration of sliding strain after manual ventilation of both the lungs. So cricothyroid membrane. So cricothyroid membrane, airway focus is often used to mark the location of cricothyroid membrane before anesthesia. So basically, this membrane in difficult airway, what you call flowchart, cricothyroid membrane assessment is important, because in very difficult cases previously they used to what you call create an air entry at the location of this membrane. Okay. The focus is often used to mark the location of cricothyroid membrane before anesthesia. This can be performed in a known or suspected difficult airway in preparation for potential cricothyroidotomy. So in cases such as CICO, that is cannot intubate and cannot oxygenate scenario. So once when we know that we are going to land up in difficulty, prior to the technique only, they take an ultrasound probe and they mark the cricothyroid membrane, and later on they proceed with their regular technique. And if there is any difficulty, immediately they what you call identify the cricothyroid membrane and proceed with their plan B. Both transverse and sagittal scans have significantly higher success rates in identifying the cricothyroid membrane than traditional palpation and landmark technique. This has also been shown in patients with high BMI and especially in pregnancy. So these are the images. So parasagittal view at trachea and at cricothyroid membrane. So ideally, I could not get a better picture of all these things. So putting probe on that side, we can see that thin streak of white line. Below the white line only, there is cricothyroid membrane. See, I think this is bit better picture. When visualizing the cricothyroid membrane in the sagittal plane, the tracheal rings resemble a string of pearls. See, uh, the white line which we can see towards the cranial part, that is the cricothyroid membrane. This view was taken in left sagittal view. We are seeing the picture. Okay, so in this picture, that is T is tracheal opening. These are tracheal rings, and C is cricoid cartilage, and the white line which you are able to see, that is cricothyroid membrane. So tracheostomy procedures, and tracheostomy procedure, before that doing tracheostomy procedure also, we can do ultrasound, because CL larynx, the anatomy is completely distorted. Even the point of entry, we can decide using ultrasound only. And sometimes, because of CA condition, even the what you call cricoid rings cannot be palpated, either because of any tumor, or else because of too many cycles of radiotherapy. There will be a difficulty in what you call assessing the cricoid rings. Ultrasound will help in doing so. So identification of trachea can be challenging in patients who are obese, have neck masses, or have had previous surgeries or radiotherapy to the head and neck. The point of care ultrasound can identify the tracheal position, depth, and the presence of any overlying vessels at the proposed insertion site for percutaneous or surgical tracheostomy. Ultrasound also aids in selection of best tracheal ring interspace for the insertion, while providing information on the size and type of the tracheal tube required. So, electro transtracheal cannulation and emergency cricothyroidotomy. So, successful location of trachea plays an important. So, before uh, the procedure only, when the patient is awake, with the prior examine everything, the tracheal opening and cricothyroid membrane, and they do all their required markings, and then if they are unable to, immediately they jump into what you call doing tracheostomy. Sorry, immediately they change their plan, that is they come for either tracheostomy or else giving airway block or anything. So how do we find out superior laryngeal nerve? It is important to give airway block in awake patients. The picture in which it shows just the mode how to hold the probe. The black color thing which he is holding, it's nothing, just a demonstration to show how to hold the probe and the position of the patient. The neck is extended, and that will be the position of the probe. The superior laryngeal nerve, located between hyoid bone and thyroid cartilage, can easily be visualized on transverse ultrasonic section across the hyoid bone. So this will be the view. The membrane between the hyoid and the thyroid cartilage, where we can see an echogenic white line, thin line, that is the superior laryngeal nerve. So this will be the point of injection for giving airway block. So fine, last point, prediction of post extubation stridor. The laryngeal ultrasound is useful.
Can you just show again for the block, please?
Sir.
ఒకసారి బ్లాక్ మళ్ళీ చూపించరా?
Sir.
Position of the probe and weight give.
Sir. So first of all, patient position will be neck will be extended, and then we will take the probe. And ideally, what we do, sir, we see directly with our hand. We see for what you call Adam's apple. Just lateral to the Adam's apple, we will place the probe. And once we place the probe, we will look for hyoid bone, and between the hyoid bone and thyroid cartilage. Between these two, there will be a thin rim of white line, which is superior laryngeal nerve. So we need, mostly in this what you call probe position, it is very difficult to give the block in plane. The preferred position of needle in for giving superior laryngeal nerve is out of plane technique, where from the side, from the middle of the probe we enter, and we deposit the drug. So laryngeal post extubation stridor. Laryngeal ultrasound is a useful non-invasive tool for evaluation of vocal cords and laryngeal morphology in intubated patients, as I already told. So the air column width measured by ultrasound may potentially identify patients at risk for post extubation stridor. What is air column width? When the tube is in place and cuff is inflated, we identify the what you call location, cuff position. We take our probe onto that area, and then we will deflate the probe. After doing proper suction, we deflate our what you call cuff and see for gap between the tube and tracheal wall. Okay, so this normally should be approximately around 6.4 mm. If the air column space is approximately 4.5 or less, then we can anticipate that post extubation patient may land up in stridor. But this is very difficult to assess. I think experts can only do this, because 4.5 mm width, and after cuff deflation, how much time we can maintain the patient in cuff deflated position, we don't know. Even though we do suction, some amount of secretions will be dribbling into the lungs. So finally, summary of my class: sensitivity and positive predictive value of traditional assessment airway assessment tools are poor at predicting the difficult airway. Advanced airway assessment techniques exist which are more informative and relatively easy to learn and interpret. So nasal endoscopy can be used in both elective and emergency settings to assess supraglottic and glottic pathology. When it comes to emergency settings, it's better to what you call give the chance of doing nasal endoscopy to ENT surgeons, because they do it regularly, and it's emergency. We are having a little amount of time, and visual endoscopy uses pre-existing CT or MRI images to stimulate the view seen during flexible nasal endoscopy. So visual endoscopy gives only our static picture, not the dynamic picture. The use of ultrasound in airway assessment is increasing. It offers additional real-time information and aids decision making. And for ultrasound also, any scar on the skin, uh, and the previous surgery and all these things, we can also we cannot use ultrasound so easily. If there is any scar or else underlying what you call uh, any cyst or Ludwig's angina, in these conditions, ultrasound may not be much helpful, though we can try. So, thank you all for your patient listening. Are there any questions?
No questions from my side, but I will have a lot of questions later on once everybody discuss. I just want to just say only 30 seconds. I'll take over. The issue is that it is very near and dear to my heart, the intubation, because when I've learned with a lot of difficulty with nowadays with the advancement of ultrasound, lot of sick. One thing is most of the people are very confident that they can intubate. Even recently, I've actually intubated one very VIP patient which has gone into esophagus, and later Manjula came and corrected it. And it can be done at any mistakes, but we have to think that way. We have to openly discuss. And a lot of very, very, very exciting things we have done, which is a difficult airway and prone position, ventilation, intubation, all these things we have done. So, but the only issue I just want to ask a few questions is, the main thing is nowadays highest sick cases comes to emergency department. In emergency department, the lowest qualified and the lowest skilled person is available at the time for the patient at night time. And that is where the lot of outcomes changes. And one question I want to ask is that most of the people nowadays in ER, people just don't want to give full sedation, just directly they give relaxant with little bit sedation. The second worry. Third worry is that recently emergency intubations can be done at the end of the bed. Those kind of things have come in recently, not just assessment of lemon and other things. So because intubation will actually kill a lot of patients because of ICP and the cardiology. Early intubation actually saves the patient. So it's really, really very nice topics. It gives me a lot of memories of what I've done, mistakes, what I've done, good things, what I did. Thank you very much, Jagdish. Maybe once everybody discusses, then later on I can ask you. Thank you.
Thank you, sir. Sir, any questions or any inputs, sir?
Let everybody discuss. If anything is there, I'll discuss. Thanks. Because everybody is there in class.
Congratulations, Omkar.
Thank you, madam.
So, in your experience, how many you faced the problems, difficult intubations, and how to rectify?
Madam, frankly speaking, in a normal any ENT case posted for surgery, and we are intubating, and our intubation goes wrong, there is few what you call some golden time where we can understand, okay, something is going wrong. But the entire intubation difficulty comes in critical care and ER, where sick cases, and also in operation theaters where patient is already having difficult airway. There will be no time at all to think. Immediately patient crashes. So in recently around 2 months back, I had an experience of intubating one MLS case only. Patient suddenly started desaturating. We know that there is a tumor at vocal cord level, and prior to that, we did awake intubation by doing I gave airway block, but uh, there was anatomy, what you call, not properly seen. So I gave blind airway and I tried my best, did the rignocaine ablations and all, but still we struggled. I had around 2 attempts I gave. We did not use long acting, we used scoline only. Tried twice, and we survived. But once there is use of ultrasound and all, madam, our decision making will be better. And one more thing is tube position. If say patient comes with pulmonary edema and it's a difficult intubation, so it will be very difficult to find out, because in ER and in ICU, ETCO2 will not be available. For them, this ultrasound will be very useful. And in my experience, madam, I have seen around 10 cases of difficult intubation. In 1 or 2 cases, monster only came and intubated. In K2, sir, I think you remember, sir, an ENT case only, where starting of the career, I was struggling, where monster came, and then he told me most of the intubations are not difficult intubations, they are made difficult by improper positioning and all. This is my little experience, madam. I think much more seniors are there. If, they will share some experience, it will be more helpful.
Why no one talking? Hello.
Hi, good morning, sir. Dr. Alok here.
Hi, Alok. Good morning.
Good morning, everyone. Omkar,
morning,
excellent class. It was really a informative class, and I was fascinated by the ultrasound usage.
Thank you, sir.
That's it. Sir, it was really very informative, sir. Anyway, I am listening to clinical things after a long time, but I was really fascinated with the ultrasound thing.
Actually, most of the times, overconfidence kills the patient. Now,
Yes,
if
sir.
anybody uses the ultrasound, if ultrasound is there, as you told rightly, upward, downward, that's called cephalic and caudal. That movement is very easy away from the airway. So if you are really, because two things every people should learn. One is a vexus presently. Second is a diaphragm movement. If these two things in ultrasound runs, it becomes easy and becomes faster. So the intubation has movement of the, because that's only opposite way direction of movement, which happens in ultrasound. But the problem with ultrasound comes is, I do not know, because if it is a blue protocol, like, red towards out and blue towards this side, that comes like that. It's not a flow, it's a movement. So definitely it's going to be very, very useful, simple way of understanding exactly, so that you can avoid 2-3 things of confirmation. One is ETCO2, second is ultrasound, and the third is looking at the ETCO2 and the expedited tidal volume. If these three things are done within 2 minutes or within 1 minute, so that we can save a lot of patients. And my real important is all these things should be learned by ER people, because they are going to be saving. Second point is that when we are giving anesthesia, we cannot give more anesthesia for hypertensive patient. We cannot give less anesthesia for a neuro patient, because that ICP changes. Most of the people, because of intubation, the real accident ICP is making so much worsening of the patient at the time of intubation. cardiac patient, more sedation, they are arresting while intubation. So that subtle, very important issues we are missing in ER. And as you said rightly, very, very useful, really exciting. You need compulsory help. A second person should be there all the time, most of the times. When you are there, then only it's better not to feel anything bad. That gives a lot of comfort, lot of ease, lot of somebody else is watching is always better. And one more important thing, what I find is anytime anybody, when you are intubating in the OT, ER, anywhere, just start holding your breath. Once you cannot hold the breath, remove the laryngoscope. That's one simple, important trick I want to tell everybody. It is not a trick, it's very important. You hold the breath and put the laryngoscope in the mouth. Till then, don't put the laryngoscope. And once you are not able to hold the breath, remove the laryngoscope. That's all. Then, particularly in anesthesia, at least he is oxygenated. But in critical care and emergency, you can't even have that much time to do. So that's the only thing which really saves the patient. Because we are interested only finding the vocal cords, we are not interested in the time. Thank you.
Sir, one more thing, sir. With the ETCO2 and lung slide and diaphragmatic movement, along with that, before intubation only when patient is awake, we can visualize the vocal cord, and we can even see the tube passing through the cord also, sir. Just theoretically, I have read it, but there are no pictures available to present it. So, but this is also there. We can identify the vocal cord, it seems, and under visualization only we can see the ET tube passing in through the vocal cord also. This is 100% confirmatory.
For this, we need extra person to do the ultrasound, I think. No?
Yes, madam. When
Then
we are,
only you can do one study for that.
yes, madam.
Actually, Anuradha has one idea regarding like stress response to anesthetist who is intubating.
Anuradha has always good ideas.
So we can all of us contribute for that. So we have to specifically monitor the anesthetist vitals at the same time when the patient somebody is intubating. We can select and do the study.
She wants it to be done for all anesthetists or only general anesthetists?
No.
All
it can be
anesthetists,
for-
sir.
all anesthetists. We can segregate like how many years of experience they have, and we can see from baseline how much of the stress response is going to happen.
Yeah, and we can subspecialty wise also cardiac anesthetist,
Yeah.
liver
Yeah,
anesthetist,
you can do
transplant
that.
anesthetist.
That we can do. But only thing is that one extra person is required to monitor the heart rate and BP of the intubating person.
Yes.
It's not because
So
of
we do that.
Manjula,
Pardon,
that is
sir?
not because of the position or procedure. It's because of the individual personality issue, that one.
That is okay, sir. But we can say, like, years of experience matters, no, sir, in that.
No. For example, now I want to see who are the people in the group here. If he is there, it's better. Sir, Raman Prasad is there?
I think he is not this.
Because Raman Prasad sir is a one person who will have a lot of stress response compared to somebody else, is my feeling. Like
No, because I just have that idea, sir, because when we do so many studies, when like during intubation, the patient will have so much of stress response during intubation. The same thing we can even apply, like the stress response to anesthetist, and that matters
no,
in long term.
that does not matter, Manjula, because sorry to interrupt, it is matters because of personality. Because for example, somebody dies, somebody emotionally is so much different. Somebody said, okay, that fellow died.
Sir, but when we take the mean and standard deviation, that will not, we can just say that 10%, 20% or 30% from the baseline.
Then it has to be like, you have to compare with the how many intubations they have done previously.
That is why I said, sir, years of experience.
But how you will standardize the patient factor?
Yeah, we have to standardize ASA by grade 1 and 2 only. ASA grade 1 and 2 and anesthetist 0 to 5 years experience and 5 to 10 years experience.
And exclusion will be difficult criteria or difficult intubation or not?
No. My MP 192.
Easy intubations, a normal routine. When you're coming to the
192.
OT, when you're changing the dress, that time you are baseline.
Okay.
Enter the OT, that is your baseline, BP and heart rate. And during intubation, that is the second. After intubation, that is third reading.
No. When you are changing the dress, it is a rate very high because you are late. That's why most of the people, it will be like, multiply is going 2-3 places. It is rate.
That
Only
is
when you are having in between coffee and chatting, that time is the baseline.
no,
coffee
sir. We
also
have the
increase.
standard 5 minutes before the procedure. We can standardize that.
Sir, one more criteria, sir. Is there any standing beside me when I'm doing the intubation, sir? That will also increase our heart rate, sir.
No. If it is your friend, it reduces your heart rate. If it is a superior, it increases heart rate.
Yeah, that's what he's telling, sir. When you are there, everybody's heart rate will be high.
So he will be excluded from the study. Sir is excluded from the study.
Then my job is at stake.
No, sir. You are outside. You are not inside the OT. That's all.
But one thing, sir, thank you, Mohan, sir. I still remember that day. It was in 2016, 2017, where first time we both were intubating the case, and I made a mess of it, and you intubated the case, and then you told me that you made the intubation difficult. It is not difficult intubation. From that day, I take proper care and do the case. Thank you, sir.
It is not for you, Omkar. It is 90% of it is true for anybody, including me also. Not anybody. Because we have my worry is that nowadays, I don't know, I want other people, so many seniors are there, I want them to talk. Because intubation is one of the important thing. If you early intubate with make a difficult, your delay intubation is difficult. Appropriate time intubation also, you are making difficulty and not giving more drugs is difficult. If you are giving less drugs and giving in parasite, it's a very, very important part because you have a sepsis patient and you 24 hours or 30 days, we put ECMO, patient dies, no use. But proper intubation can really save patients beforehand, early indications, because identification of the difficulties and proper timing of intubation, duration of intubation, and early complications. All these things, one of the important aspect of this talk is really, really important for everybody. Every MBBS doctor should know everything about this. But as Alok said, really ultrasound made, if we can really use of it, it will be really, really great. Very nice. Thank you, Alok.
Yes, sir. Ultrasound is in North. There are 4 hospitals. Everybody is having ultrasound. We have in each location, but I have not seen them using for this. I'll make all of them use now.
Yes,
Alok,
sir.
we are also using most of our procedures are done under ultrasound only nowadays. All blocks, wherever nerves are there, we are there blocking. So it is of good use in ICU and operation theater.
No, not only for blocks, for other things also, anticipation, evaluation, post-rider,
Yeah.
everything
Yes.
they can use because we have around 14 PGs on all the 4 hospitals. So we will try to use them.
So the main motto of my class was to introduce ultrasound for airway protection also, sir, because giving blocks and all, we did a lot. And now once, when one day I had a case where I was searching for something, then I came across this thing, advanced techniques. Then I went through, then I felt that this is an area where we are not at all using ultrasound. We are having ultrasound just beside us, but still we are not taking proper advantage of it. So I thought of making a class. So I hope everybody tries these things, and please put some pictures in the group, sir, if you are able to visualize anything or something new, which will be helpful to youngsters, sir.
One small thing, Omkar, I want you to put a only ultrasound airway workshop for one day. Because that can be for intubation, that can be for block, that can be for identification of diaphragm, that can be identified for blue protocol, lungs, whatever you call it as, only ultrasound for airway. And like that we can put one day workshop. That's very, very useful for all of us, whoever is in our team.
Yeah, sir,
Yes,
I will join, sir.
Yes, sir. We can do that, sir. So first I will start working on this to try to get as many pictures, because theoretically I have seen all these things. Practically, I did not start doing things, sir. From now on, I will do all those things and see what are the difficulties which we are seeing and try to get some pictures, sir. Later on, we will plan, sir.
Thank you so much. Thank you so much.
Thank you, sir. Thank you.
Thank you,
Thanks
Alok.
for all seniors.
Thank you, sir.
Thank you, Omkar. Alok sir,
Thank you all.
nice to see you, sir.
Nice to listen, hear you.
Yeah. At least video recognize, at least we can see no your face.
वीडियो है क्या मैं ऑन किया बट दिख नहीं रहा है
ये दिख
Yeah,
रहा है ना,
अभी
आप दिख रहा है, अच्छा दिख रहा है कार में.
दिख रहा है, स्मार्ट हो
मेरे को
गया,
नहीं दिख रहा है
थोड़ा
स्मार्ट
थोड़ा
हो गया
स्मार्ट
सर.
स्मार्ट फिल है ना, ज्यादा फैन हो गया.
नहीं सर
Okay.
सर एयरवे में आऊंगा मैं सर आई विल जॉइन इन
Yeah, sure. Airway workshop, you will be there. Fine.
and I will induce all my hospitals here to start using airway,
Excellent.
ultrasound and airways.
Yeah. Yeah.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you.
Bye
Thank
bye.
you, sir.
Thank you,
Thank you
Omkar,
much.
for a nice class.
Thank you.
Thank you. Nice class.
Thanks.
Thank you
Thanks
to
for
all.
seniors,
Thank
sir.
you, Omkar.
Thank you, madam. Thank you all.